Welcome back to Basic Concepts of Nursing. This is Tracy Hansen again, and we're going to be moving on to really getting our patient prepared and prepped for surgery. We've talked about some of the things we need to do. I would say obtaining that informed consent is going to be of primary importance. We also need to consider dietary restrictions. You have all heard the phrase NPO, which means nothing by mouth, be it eaten, drank, smoking, sucking on hard candies, doesn't really matter, just nothing by mouth. And typically what we see is orders for our patients to be NPO after midnight, which means nothing to eat or drink after midnight. Patients are given written as well as oral directions, and we do stress the importance of adhering to the NPO policy. And surgery can and oftentimes is canceled if the patient is not NPO. The thing with NPO, what brings it to light right now is that with preoperative fasting, are these time frames too long? And if you look in Chapter 16, there is some evidence-based practice talking about the new guidelines, because the American Society of Anesthesiologists have really looked at the time frames patients are NPO, and you might be NPO after midnight, and you might go to bed at 10 o'clock at night. So that would be 2 hours already, and if your surgery isn't scheduled till 8, then that puts you at 10 hours. If maybe your surgery gets bumped back and maybe it's 10 o'clock in the morning, then now we're at 12 hours. And we know that when patients are NPO or fasting, it tends to slow the metabolism down. And as our metabolism slows down, that will decrease insulin sensitivity. And with insulin sensitivity being decreased, then our cells become resistant, and that causes us to have elevated glucose levels, which puts us at risk for infections such as UTIs, impaired wound healing, those types of things. However, with surgery and fasting, the fasting causes a decrease in metabolism. However, surgery, the stress of surgery, we know that stress increases metabolism. So surgery actually increases our metabolism due to the stress that we're putting on the body. And when we don't have those glucose reserves, or we don't have the glucose available, that causes catabolism, which causes increased insulin levels, but the cells are more resistant, and so it's just kind of a vicious cycle, and something that is important to consider when we're looking at NPO status. When I talk to you about infants, we suggest, infants really can't go very long without food. And if you would take a look in your book, when it starts discussing NPO, it talks actually about how much time does it take to have a gastric emptying content time in the normal healthy adult. And, you need to look at it. Is it clear liquids, breast milk, infant formula, non-human milk, so bottle fed? Is it a light meal, or is it a regular meal? And actually, the American Society of Anesthesiologists have suggested the guidelines of clear liquids only require 2 hours of fasting, breast milk 4 hours, infant formula, non-human milk, and light meals 6 hours, and then regular meal, again, just 8 hours. And these were all suggestions made by anesthesiologists. And the downside of this is that it's really having a very slow reaction time as far as patient education goes, and oftentimes they're chalking that up to the fact that physicians or surgeons and nurses, we don't want to take the time to accommodate for each different patient, and we don't want to individualize patient teaching. So it's just best to say, you know what, you're NPO after midnight. And I think that, as we grow in nursing, and as patient safety and patient initiatives come to light even more, especially with under new legislation with Obamacare, we're going to see changes in focus because that our national health care is really looking toward disease prevention. So we're looking more at how can we keep people healthy, how can we prevent adverse outcomes. So you may see in your nursing time this NPO status changing. And I will also make a copy of a preoperative fasting journal article that was just recently written in 2011 that does accompany what and support what is in your textbook as well. Administering regularly scheduled medications, really, across the board, we're seeing this done much more frequently. However, it is not standing practice. You still need to have a physician's order, so you need to be talking to the physician. What did your ask your patient, what did your physician tell you to do? If they say, well, my physician never said anything about any of my medications, so I really don't know what I was supposed to do. So then at that point, you'll need to contact your physician or nurse anesthetist, anesthesiologist to find out what they would like done. It is important for people to take regularly scheduled medications, especially related to these disease processes here that are listed on your slide: cardiac, respiratory, seizures, and hypertension. The one drug that we do tend to see being altered is that of insulin. And diabetic patients that are on long-acting insulins, that take long-acting insulin at bedtime, typically will need to cut that dose down so that they don't have the long-standing effects of insulin and surgery, because really the only way to replace that if you have a patient that's NPO and asleep on a surgical table is to administer D5W, and D5W isn't always compatible with everything, so we do tend to see our diabetics cutting that night before insulin in half. We see them not taking oral antidiabetics, especially the morning of surgery. And then we see their blood glucose levels being covered with just subcutaneous regular short-acting insulin via a sliding scale. And we'll get more in depth with sliding scale insulin and those such things in advanced concepts. But it is important to know that our diabetics, they are the ones that we might see those medications being held that morning of. Skin preparation. So when we talk about preparing the skin preparation, it can be embarrassing to our patients. It can be uncomfortable. It can be sensitive. So it's going to depend on where you are prepping. So if you look at page 255, you will see different preps that we do for surgeries. Typically the day before surgery, the surgeon asks the patient to shower using an antiseptic solution, and then the morning of surgery they will also be asked to shower with the same type of solution. When they come in to be prepped for the surgical procedure, that cleaning is repeated typically by just a scrub, and our goal is to reduce the number of organisms that are on our patient's skin, because we do know, and you are well informed from intro to nursing, that our skin is obviously our first line defense. However, our skin is covered with lots of organisms that can predispose our patients to wound contamination, surgical site infection, and those types of things. Hair clipping is done with electrical clippers, and we use the electrical clippers rather than shaving, because the shaving will increase risk of infection, because we would be very prone to maybe cutting our patient's skin. And with the surgical surgical clippers, we don't run that risk of cutting our patient. Typically what the prep will be done prior to the patient heading back to surgery. If it is in a sensitive area, if your patient would need to have be in the lithotomy position and need to have very low perineal shave done, oftentimes you'll see that done in the surgical room right after the anesthesia is administered, just to prevent that embarrassment to the patient. Patient and family teaching, we need to educate our patients about tubes, drains, vascular access. One of the things that you will be required to do is always start an IV preoperatively. And so if you look at this picture down here, you'll see that we have a green, a pink, a blue, and a yellow catheter. When we talk about those, I would suggest, and it is very important for you to know what each of those colors represent, because it is going to be important that in surgical patients we typically try to put in an 18 or a 20. An 18 is green. It's the largest, it's not the largest bore, but it's typically the largest bore that we're going to use in surgery, just going into a normal surgical procedure. Next is the pink 20. The blue is a 22. And a yellow is a 24. And the yellow is what you might see on the very frail population, what you'll be seeing used in kids in pediatrics. So I would make yourself familiar with what the colors, what the color hubs of those vascular access devices represents. Drains, the other picture next to the IV, this one here, is a Jackson Pratt or JP drain. So we will need to discuss with patients how to care for those drains. And with caring for a JP drain, our patients now need to know how to empty it, how to record those findings, and then to compress the bulb prior to closing it so that so that suction is maintained. So some of those things will be under dressings, maybe, but we do need to just educate our patient as well as their families on some things to maybe expect post-operatively. Nasogastric tubes, you all have learned how to insert NG tubes in Intro to Nursing. You may see NGs put down patients that have some type of bowel obstruction, any kind of colon surgeries where there's an obstruction, and so you know how to put those down. I'm not going to spend a great deal of time discussing them, but our patients would probably much rather be put to sleep than be awake when we're putting those NGs down. Intestinal preparation, with intestinal preparations, that's just talking about cleansing the bowel basically to reduce number of intestinal bacteria present. In the old days, not to date myself, but 20 years ago when I started nursing, honestly, we did bowel preps on pretty much everybody. We gave them enemas, we gave them laxatives. Anybody having any kind of abdominal, pelvic, perineal, perianal, any of those surgeries, they got enemas or they had a bowel prep. And then along with the enema or laxative, they were also given oral antibiotics, neomycin, to continue to destroy bacteria. However, we know that when we destroy our normal flora, what happens to us females? Ooh, sets us up for yeast infections. Repeated enemas can cause fluid and electrolyte imbalances. Fluid volume deficit can cause a vasovagal response, and the vagal response is like passing out. So if your patient has a vagal response, they kind of pass out. There's a response to the vagus nerve. Other physicians, the potent laxatives like the Go Lightly or the polyethylene glycol electrolyte solution, we see a lot of that used, and go lightly does not mean that you go lightly. It means that your stool will become light. The idea behind it is that the stool becomes really pretty much clear as water. And so you may be seeing those kinds of things used. The downside always is fluid volume deficit, fluid electrolyte imbalance, and then how's our patient going to tolerate that? Go Lightly is at least a gallon jug, and the patient is expected to drink pretty much all of it. And if you have an elderly person trying to get to and from the bathrooms, that's going to be safety consideration, and it can be very exhausting. So we do need to consider patient safety, and I think that's why we've really moved away from most of the intestinal preparation. However, they are still being done. Thank you for listening to this section, and we will move on to complications and preventive of complications during the perioperative period. Again, if you have questions, please write them down and we'll discuss them further in class.